Everyone to meeting number 42 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation facing Canadians in light of the COVID-19 pandemic. I would like to welcome the witnesses. From the Canadian Association of Optometrists, we have Monsieur Francois Couillard. We have Dr. Michael Nelson, Laurel Crabb-Lauren. From the City of Windsor, we have Mayor Drew Dilkins. From the region of Peel, we have Dr. Lawrence Lowe, Medical Officer of Health, Public Health. Dr. Jennifer Liu, Acting Medical Officer of Health and Chief Executive Officer, Algoma Public Health. And we have Dr. Christopher Mackey, Medical Officer of Health, Middlesex London Health Unit. And we have with Unite Here Canada, we have Michelle Travis, Research Director, and Elisa Cardona, Hospitality Worker, Local 40. Kieran Dillon, Hospitality Worker, Local 40. And with that, we will invite the witnesses to make a 5-minute statement. I'll display a yellow card when your time is nearly up, and I'll display a red card when your time is over. If you see the red card, you don't have to stop right away, but do try to wrap up quickly. And with that, I will invite Canadian Association of Optometrists, Monsieur Couillard, I believe. Go ahead, please. 5 minutes, sir.
Thank you very much, Mr. Chair. Good morning. Thank you to all the members of the House of Commons Standing Committee on Health, in particular Luc Thériault, the member for Montcalm, for the opportunity to present on behalf of the Canadian Association of Optometrists. My name is Dr. Michael Nelson, and I'm the president of the association. I'm also a practicing optometrist in Winnipeg, Manitoba, and I'm joined by Francois Couillard, our CEO, and Laurel Crabb-Lauren, our senior manager of government and stakeholder relations. The Canadian Association of Optometrists represents over 5,400 optometrists who serve as Canada's primary eye care doctors. Our experience during the COVID-19 pandemic has been an increase in patients complaining of a variety of vision problems. Canadians are realizing the importance of their vision and that they should not be taking it for granted. Optometrists are seeing higher rates of eye fatigue, increased incidence of disease, and a growing rate of myopia. And conditions like diabetic retinopathy, which can lead to vision loss, have worsened as some Canadians chose to delay their routine eye exams. The growing myopia rate is especially alarming for optometrists and should raise a flag for government. Last year, the World Health Organization's inaugural World Report on Vision included some startling findings. Now listen to this. The rate of myopia is expected to rise from 28% in 2010 to 50% by 2050. Now, this is very alarming as myopia increases the risk of glaucoma, retinal detachments, and vision loss in adults. And while heredity plays a large part in myopia, it is further exacerbated by what we have seen through the COVID-19 pandemic, with more and more kind of near and close time and not enough outdoor time. And this is especially worrisome for children because of the increased screen time for school and recreational activities. Now, for those living with diabetic retinopathy, a condition that is particularly predominant in Indigenous populations, the problems of accessing care during the pandemic have resulted in worsening eye health.
Certaines questions de politique de haut niveau.
Some high-level policy questions merit the attention of the federal government. They will have a major impact on not only the health of Canadians, but also on the economy and the productivity of our nation. A Deloitte Access Economics research paper released last month estimated that the total financial and economic cost of vision loss in Canada was $15.6 billion in 2019. This was before the COVID-19 pandemic. The lack of a coordinated system of primary eye health and vision care was especially apparent during the COVID-19 pandemic, which dramatically reduced the ability of optometrists to provide care to Canadians. Vision issues touch all Canadians, with 6 in 10 report having had a vision problem. On an annual basis, almost 1 million Canadians miss work or school or have their performance affected because of vision problems. We would encourage you to support a vision study at the Standing Committee on Health once this pandemic is over. For some reason, Canada's many healthcare systems do not acknowledge that our eyes warrant the same level of care as other body parts, However, eye health and access to proper vision care for all population needs to be more of a priority. We have an opportunity to ensure that comprehensive eye health and vision care be included as an integral component of healthcare delivery from birth. 75% of vision loss can be treated or prevented, which means that early detection and treatment can improve population health and help circumvent costlier treatment and intervention in the future. Thank you very much for your attention.
Thank you. We go now to City of Windsor, Mayor Dilkens. Mayor Dilkens, go ahead, please. 5 minutes.
Thank you very much, Mr. Chair. And it is windy here from time to time just today, but I thank you to you and members of the committee for the opportunity to appear today and make the case for border communities, not just Windsor, but across the country, to gain access to surplus vaccines that have been offered by our neighbors in the United States. In my community, prior to the onset of the pandemic, the border between Windsor and Detroit was much like that between Ottawa and Gatineau in the shadow of Parliament Hill. Thousands of healthcare workers live in my community but cross to work every day in Detroit. At the onset of the pandemic, when Detroit was a hotspot for cases, in fact, among the worst in the United States, Canadian nurses crossed the border each day to support the healthcare system in Southeast Michigan. It's no exaggeration to suggest that without Canadian healthcare workers, entire hospitals would have closed in Michigan, creating widespread problems. In fact, the United States State Department recognized this invaluable contribution, and the U.S. Consul General came to Windsor, and he and I handed out thank you gift cards to doctors and nurses and pharmacists who were crossing at the Windsor-Detroit Tunnel and the Ambassador Bridge. That was April 2020. When the vaccines began to be delivered, the City of Windsor stepped up to support all aspects of the process. Hundreds of city staff have been redeployed to support different mass vaccination clinics across Windsor. We set up a special call center to help ensure the process was smooth and efficient. It hasn't been without challenges, the largest of which relates to the mismatch between supply and demand. In the beginning, we had 12,000 seniors over 80 years old on our wait list. Some had waited for 6 weeks for the phone call to book their first appointment. I actually booked 100 of these appointments myself. And when I called one 86-year-old, she broke down crying on the phone with joy. She hadn't left home for 6 weeks. She wouldn't even take out her recycling without bringing her phone for fear of missing the call that would set her on the path to once again hug her grandkids. The problem is the fear and uncertainty she felt in the beginning is only exacerbated after she received her first shot, because we told her to go home and wait for up to 4 months now for someone else to call and book the second appointment. Members of the committee, we can and we must do better until everyone has been fully vaccinated. Today, multiple medical officials in Detroit and in the state of Michigan have offered to provide us with surplus vaccines, many that would otherwise expire and be thrown away because vaccine uptake is slowing just 2 kilometers away in Detroit. Last week, it was reported that the state of Michigan saw 35,000 doses hit the landfill. And I submit to this committee that those were doses that could have gone into the arms of Canadians. I appreciate that there are a host of issues that would need to be resolved in order to make this sort of international inoculation effort possible. And I'm not here to minimize or trivialize the effort that's required to make this happen. But I am here to advocate for that effort to be spent, because it would help get Canadians access to their second doses faster than would otherwise be the case. The federal government's COVID-19 testing and screening expert advisory panel report released on May 28th specifically highlights that Canadians with only one dose are at a significant public health disadvantage. I appreciate that a pathway exists for Canadians to get fully vaccinated based on the supply procured at the national level, which is allocated to the province. But this process will take months to hit all eligible Canadians, and multiple offers for surplus vaccine have been made to Canadians from U.S. counterparts today. An urgent dialogue is required with all respective parties on both sides of the border to find a way to make this happen. Throughout this pandemic, governments at every level, they have found ways to move mountains to safeguard the health and the safety of the public. Policy initiatives that would otherwise have taken years get resolved in the matter of days. And I commit to doing everything and anything in my power to create the conditions for success. Last week, the board of the Windsor-Detroit Tunnel Corporation voted to authorize the closure of the International Tunnel for the purpose of hosting a vaccination clinic at the borderline below the Detroit River. I established an online waitlist for Windsor-Essex residents who are ready to stand in line for U.S. surplus vaccines. As of today, we have over 11,500 Canadians who are on that list. Creative solutions have been found at the Carway crossing between Alberta and Montana, and I congratulate everyone involved on both sides of the border for the creativity employed to make the right thing happen there. Surplus vaccines from Montana are getting into the arms of waiting Canadians, and I'm asking for that same type of creativity and effort to be as well, so that we can accomplish our shared binational goal to fully vaccinate our residents, so that we can reunite families, reignite our economies, get people back to work, get businesses open, and reopen the world's longest undefended border. But I need help and leadership from our federal government, and I'm here again asking for that today. Thank you, and I look forward to the questions and discussions this morning.
Thank you, Mayor. We go now to Region of Peel, Dr. Lawrence Lowe. Please go ahead, sir, 5 minutes.
Good morning. Thank you, members of the committee, and thank you for the opportunity to present today. I will be focusing largely on my experience as Medical Officer of Health for the Region of Peel, but I'm honored to be here today as well with my colleagues, Dr. Chris Mackey from Middlesex London Health Unit and Dr. Jennifer Liu, Middlesex Medical Officer of Health for Algoma Public Health, who will be able to complement their experience from other areas in Ontario. Peel Region is one of 34 public health units in Ontario and serves 1.5 million people in the cities of Brampton and Mississauga and in the town of Caledon. And as many of you on the committee likely know, Peel Region has been one of the most impacted regions of COVID-19 in Canada due to population factors such as a large proportion of essential workplaces, as well as socio-demographic and economic diversity. We are also home to the country's busiest international airport, which has been a source of introduction of variants of concern into our community. Throughout the pandemic, local public health efforts are supported through ongoing collaboration with federal and provincial partners, our local municipalities, and community partners. Some specific examples of the support that we have received in Peel from the federal government include $6.5 million in funding from the Public Health Agency in Canada to support voluntary isolation housing for residents who cannot self-isolate at home. $13.1 million in funding received through the Reaching Home program to make a meaningful impact in supporting some of our most vulnerable residents, as well as federal support for Canadian Armed Forces for long-term care outbreak management to protect some of the most vulnerable seniors living in long-term care settings in our community. We've been greatly appreciative of these and other supports we've received, and we recognize that there are other areas where our collaboration can be strengthened. In the short term, financial support from both provincial and federal governments have aided our immediate pandemic efforts, which in Peel, those efforts have entailed the redeployment of most of our staff, new hiring, and the suspension of most of our public health programs. We're grateful for this support. However, looking to the longer term, the federal government could further assist Peel Public Health and public health units in Ontario by allocating public health specific funding in provincial transfers, as most health funding is traditionally used for healthcare provision, enhancing resources and governance of the Public Health Agency of Canada to better support a national response to infectious diseases, which would include autonomy and authority of the Chief Public Health Officer to direct public health measures, including the maintenance of international surveillance programs, and also added resources to address other non-COVID public health crises that existed before the pandemic, such as the opioid epidemic, and those that will arise due to the delayed provision of public health services. We would be happy to expand upon key COVID issues faced by the public health sector during the question and answer as needed. Another area for review would be outbreak management in First Nation communities, where my colleagues on this call today with me from Middlesex London and Algoma have reported taking on a primary role at the local level in responding to what is a defined federal mandate, which may require supplementary support and resourcing. The federal government can also support our pandemic response through enhanced travel and border control measures to further decrease an influx of variants of concern or interest from interprovincial and international destinations. We support federal and provincial measures to restrict non-essential travel, and to emphasize the level of concern, Peel Regional Council recently called for the suspension of all non-essential travel from interprovincial and international destinations to Toronto Pearson International Airport. As the international situation changes, prompt adjustments to travel restrictions should be implemented. Dr. Liu will also be able to speak to an additional point regarding Algoma's experience with the land border, where their experience has underlined a desire for local input into any proposed restrictions that have impact on our community. Parallel to this, it is important to also protect those who are vulnerable and impacted by restrictions. In Peel, this includes international students that arrive in Canada. Many of these individuals are targeted by marketing from unscrupulous landlords and are charged very high amounts to share inadequate living spaces during and after isolation. Support from the federal government could assist arriving students to be provided with better information about their isolation options on arrival. We also need to ensure that our workforce is protected. In Peel, our large essential work sector, an analysis found that 25% of workplace outbreak cases had reported going to work even after symptom onset. Without proper sick leave, essential workers are often unable to isolate or stay home when ill or access vaccination in a timely manner. The previous enhancements to the Canadian Recovery Sick Benefit and Ontario's new Worker Income Protection Benefit are steps in the right direction. However, further improvements to the program could include minimizing interruption of income flow for individuals with timely release of funding and removing the criterion required demonstrating loss of 50% income prior to application. These changes would remove barriers and would help to ensure that our workers can follow public health guidance when they're sick. In Canada, public health is a shared responsibility between all levels of government. Coordination and collaboration are essential, and ensuring flexibility to meet local challenges is equally important. Moving forward, support from multiple levels of government with local action are essential as we move out of the response and into recovery. My colleagues and I are happy to answer any questions that you may have. Thank you.
Thank you, Doctor. We go now to Unite Here Canada. Ms. Travis, Michelle Travis, go ahead. 5 minutes, please.
Hello, I'd like to thank the committee for inviting us here today. My name is Michelle Travis, and I'm the Research Director for Unite Here Local 40, the Hospitality Workers Union. COVID-19 has had a devastating impact on hotel workers who were put out of work by the pandemic. Nowhere is this more true than at Pacific Gateway Hotel, which was taken over by the federal government under the Quarantine Act last year. Shortly, you'll hear from 2 workers who have been directly impacted by the takeover and are calling for government action. The government is spending untold amounts of public money on a hotel that recently fired over 140 long-term workers, mostly women. There's no transparency on the terms of the federal takeover or how long they will stay. We've asked for a copy of the agreement between the government and the hotel, but the hotel says there is no contract. Hard-hit workers deserve to know why the government repeatedly extends its time at and subsidizes a hotel that takes advantage of the pandemic to fire much of its staff. Workers should be allowed to return to their jobs as travel restrictions ease. Every day the government subsidizes this hotel, more workers risk losing their jobs. We are urging the government to state its end date at Pacific Gateway, share a copy of their agreement, and please move to another site. Now I'd like for you to hear from Elisa and Kieran. Thank you. Elisa?
Good morning. Thank you so much for your time. My name is Elisa Cardona, and I worked full-time for 7 years as a hostess and server at Pacific Gateway Hotel near Vancouver Airport. When the government took over the hotel, they brought in the Red Cross. Some of us were displaced from restaurant, kitchen, and housekeeping jobs. The government has repeatedly extended its takeover of our hotel. We were told they would be out last May, then August, then November, then it got extended to March 30th of 2020. Now it will be through the end of the summer of this year. The hotel has used the federal takeover as an excuse to terminate me and 142 of my coworkers. That's over 70% of our staff. Many of us were fired in the last 2 months. Many of us are women. I'm a single mom raising 2 children, ages 12 and 14, and I've been worrying about my finances and money this past year, and it's been incredibly stressful for me and my family. I expected to go back to my job when it was time. We asked the hotel to allow us to return to our jobs after COVID-19 has passed and when the work becomes available again. They have refused the whole time. The federal government is subsidizing a hotel using a temporary pandemic to fire and replace us for less. These have been good family supporting jobs. Why is the government allowing this to happen? Prime Minister Trudeau promised us a feminist recovery. Yet, women are bearing the brunt of firings at Pacific Gateway on the government's watch. A human rights complaint has been filed against the hotel for sex and racial discrimination on women because jobs have been disproportionately impacted. How much has the government spent on this hotel while women like me are treated like we're disposable? After the latest round of mass firings, we went on strike and remain on the picket line. What's happening in our hotel is not acceptable. The government can and should act. That's why we're asking the government to stop subsidizing Pacific Gateway Hotel. Thank you.
Good morning, everyone. My name is Karen Dillon. I worked as a room attendant cleaning hotel rooms at Pacific Gateway for 17 years until the pandemic hit. I raised my children on this job. When the government took over our hotel as a quarantine site, they brought in the Red Cross. Other people were trained to do our jobs. I was terminated last month along with my many of co-workers. The hotel fired 90% of housekeeping staff. Most of us are women who have been working there for decades. Women at Pacific Gateway are taking the brunt of job losses while men's jobs are more likely to be protected. We filed a human rights complaint on the basis of sex and racial discrimination because of how we have been treated. The hotel terminated 74% of its female staff. More of my co-workers could lose their jobs this summer if the government continued to use our hotel. My co-workers and I want to know when will the government stop using Pacific Gateway, and how will the government help women like me return to our jobs so that we aren't treated like we are second class. People want to travel again. There's no reason why we should lose our jobs during a temporary pandemic. Thank you so much.
Thank you all. We will start now with question. Start with Ms. Rumpel-Garner. Go ahead, Ms. Rumpel-Garner, 6 minutes, please.
I'll be directing my questions to Mayor Dilkins, but before I do, I just want to say to Ms. Cardona and Ms. Dillon, your testimony was shocking and should wake every member of this committee up. I can't believe you had to go through that, and I reiterate calls for the government to scrap the non-scientific and discriminatory hotel quarantine program. I am so sorry you've had to go through that, and I'm in shock. It's ridiculous. Mayor Dilkins. It's my understanding that prior to this meeting, about 3 minutes before the meeting, you got some correspondence from PHAC that said that if a US pharmacist reached her hand across the borderline to give a Canadian dose that would otherwise go in the garbage, that it would be considering importing the drug for sale and would need Health Canada approval. Is this correct?
That's correct.
Do you believe that the government, or has the federal government offered you any assistance in getting these doses into Canada?
No, none whatsoever.
Would you say that they've been more focused on providing roadblocks to getting these doses into Canada?
Every effort to find creative solutions to make this work has been thwarted.
Would you characterize that the government the Canadian federal government is in fact comfortable with 35,000 doses going in the garbage?
Well, it would appear that way. I mean, we have 35,000 doses that hit the trash 2 kilometers away from where I'm sitting at the very moment in the state of Michigan, doses that have been offered to us by pharmacists living in my community who work over there, who are just beside themselves thinking that this stuff is going into the landfill when there's such a demand here on our side of the border.
Do you think would you characterize that as sort of like the height of privilege in terms of watching vaccine inequity around the world and the Canadian federal government being content to let doses of Pfizer vaccine go in the garbage?
I just think we can do better. We have a pathway to do better, and it's not worse on the U.S. side in every situation at all times. And this is being offered to us. And for some reason, our government is finding every way to say no to making this happen. I'm looking for someone who will find one way to say yes. This is a sensible pathway. It's Pfizer vaccine that's manufactured at the same plant in Kalamazoo, Michigan. Let's just find a way to make this happen.
The head of PHAC in front of this committee said that every Canadian currently has a pathway to a vaccine, and then made this sort of glib comment about a Twitter account, Vaccine Hunters. Would you characterize that as correct in your community right now? Does every resident in your community have a current pathway to, let's say, even a second dose of vaccine? Like if anybody in your community, could they go and get a second dose today in Windsor?
No, if they could, I wouldn't be here. That's the problem. There's a supply and demand mismatch, and this was a pathway to help make our situation better on this side of the border.
Do you think Health Canada and PHAC are just being obstinate? Like, I don't understand why they're not helping you. Could you share some light on that? Like, are they just... being obstructionist for the sake of being obstructionist and their privilege?
The part that's difficult for me to understand is that pathways have been found. I'm not asking for something unique here. There are pathways that have been found at the Carway crossing between Alberta and Montana. In fact, tomorrow and Wednesday, there will be further Canadians crossing at that port of entry to get their vaccine and returning to Canada. So I'm trying to facilitate the same type of thing here in my community because the vaccines are being offered. And it's people who live here who are calling me saying, Drew, I'm throwing this stuff in the garbage. How do we get it into our supply chain so that we can help vaccinate our population?
Have you had any like pushback from anybody on the American side, be it officials or health providers? Like, is anyone signaling to you, no, we don't want to do this?
My conversations, I've spoken with the head of the of U.S. Customs, the one responsible for the port in Detroit. They have concerns with the vaccination on the U.S. side at the port of entry. And so they said that they don't deem that to be essential travel into the United States. So that's why we've had to work on other creative ways in order to try and make this happen, which is why we painted the line in the Detroit tunnel.
Do you think that is perhaps, like, would you speculate that that's due to the fact that the Canadian federal government really doesn't have any plans or benchmarks for reopening the U.S. border in spite of calls like, let's say, Republican Congresswoman Elise Stefanik saying that they might have to unilaterally open the border? I guess I'll close with this since we have you here. If the Americans unilaterally open the border, as Elise Stefanik has sort of alluded to today, do you think PHAC or anybody would have the resources to follow up with the tens of thousands of Canadians that would almost certainly cross the border to get vaccinated?
I am the mayor of the city that is the closest city to the United States, a major urban area on the other side of the border. When the border opens, if it opens later this month, there will be 10,000 people crossing in the first couple of hours to get their second vaccine, to pick up packages, most importantly, to visit loved ones they haven't seen in 15 months. Our system will be absolutely overrun. But the thought is that you have to be fully vaccinated plus a 2-week window after your second vaccine to be considered fully vaccinated. The system will be completely overloaded at this port of entry very quickly.
Do you think any member of this committee should be comfortable? I have 30 seconds left. Do you think any member of this committee should be comfortable with 35,000 doses of the Pfizer vaccine being thrown in the garbage?
You do not have 30 seconds left.
No.
I did. Thank you.
Thank you. We will go now to Ms. Sidhu. Ms. Sidhu, go ahead. 6 minutes.
Thank you, Mr. Chair, and thank you all the witnesses for joining us today. I'll be directing my question to Dr. Loh, but I would first like to thank him and his team for all the hard work that he has done in our community during this pandemic. So Dr. Loh, the new Delta variant has been found in our community. And on June 2nd, you said that we need to move quickly for second dose in Peel and other hotspot zones for maximum protection. And I agree with you that there is a need for this prioritization. Have you heard any feedback from the provincial government on prioritizing hotspots for the second dose?
I'll preface my answer by saying that there may be a difference of opinion, at least amongst the three of us medical officers of health here, at least in respect of that. But my recommendation is not my own professional opinion, but is simply reporting a recommendation made to me by the Ontario Science Table, which indicates that the Delta variant is increasing rapidly throughout the province of Ontario, and that the region of Peel is the furthest ahead in terms of its replacement of the Alpha variant with the Delta variant, thus necessitating potentially a consideration for prioritization of second doses for protection.
Thank you. On April 20th, you made the courageous decision to shut down workplaces that see outbreaks of 5 or more employees in order to prevent the workplace to spread COVID-19 in our community. Do you think there's anything additional that the province could have done to prevent workplaces transmission during the height of the third wave in Ontario?
So workplace transmission has been a significant issue throughout the course of the pandemic in the region of Peel. We've always talked about the need for investigations, inspections, and protections. In respect of investigations, that really speaks to making sure that workplace outbreaks, et cetera, workplace outbreak investigations are conducted in a timely manner and where they cannot be we brought our Section 22 order into place. But it's not just that in and of itself. We know that paid sick days, we know that things like proactive workplace safety inspections, these are all things that we've had dialogues with our provincial partners on and have seen some movement on, but certainly would be desirous of continuing to work to really address spread in workplaces in our community, which has really been part of the reason why Peel Region's transmission rates have looked the way that they do.
And Brampton is one of the most racialized community in the entire country. I'm concerned that many of the policies by the Ontario government are disproportionately affecting essential workers who cannot access sick leave, those living in multi-generation households and workplaces that may not be considered truly essential. Do you think the Ontario government has sufficiently examined the impacts of their policies on the community in Brampton?
So thank you, Member Sidhu. I mean, I know that we've had numerous productive dialogues with our provincial counterparts. They understand and have expressed support for the unique challenges that we face in the region of Peel. But certainly things like paid sick days, proactive workplace inspections, et cetera, these are all things that are needed. And I would also highlight that many of the challenges faced in Peel have also been just disparities that have existed even prior to the arrival of the pandemic in our community, just reflecting the socioeconomic and ethnocultural diversity in our community.
Thank you, Dr. Lowe. You said in your statement, most impactful region, Brampton has been hardest hit in the entire province of Ontario. We have seen the horrible impacts of the virus on our communities, workers, and families. Have you provided any advice to the Ontario government that could have prevented the severity of the tragedy, and did not province take that advice and really want to see your advice on that?
Like as I've mentioned, Member Sidhu, I think we've regularly provided input to the Chief Medical Officer of Health and the Ministry around measures that could be used in workplaces, around testing, around vaccination strategies, et cetera. And to the extent that some of those are taken up in part or in whole, I'd be hard pressed to remember exactly which and where those policies have landed. But what I do know is that like I said, the story of Peel has been a story of disparity, and ultimately really reflects the socioeconomic and diversity challenges that we have faced throughout this response that existed long before COVID-19 arrived.
And thank you. Peel was one of the first communities to have a federally funded voluntary isolation center to help quarantine people who were not able to safely do so at home. Can you speak to the effectiveness of this service?
Absolutely. Thank you, Member Sidhu. So this isolation program has been extremely supportive in the course of our pandemic response. We've had over 2,500 individuals stay in our isolation housing locations, and that does include locations that have been both provincially and federally funded, and we are continuing to evaluate the course of this program. We do believe certainly improved coordination of funding between provincial and federal levels for isolation housing could help to mitigate administrative burden for our staff and our partners. But we are certain that having had that facility in our region has been helpful in terms of addressing potential spread within households, which has also been another significant driver in our community.
And in your opinion, has the Ontario government done enough to curb community transmission in first, second, or third wave?
I think there have been numerous opportunities and that we've had with the provincial government and discussions that continue. And I'm hopeful and looking forward that we'll be able to do the right thing, at least with the rise of the Delta variant in our ongoing vaccination program. Thank you.
Thank you, Mr. Du. Nous allons maintenant à Monsieur Thériault. Monsieur.
We now move to Mr. Thériault. Mr. Thériault, go ahead, please, 6 minutes. Thank you, Mr. Chair. My questions will mainly be for the Canadian Association of Optometrists. I don't know if it would be Mr. Couillard or Mr. Nelson. You can see who wants to answer the question. At the outset, can you tell us what research is being done on for optometry in Canada now? Generally speaking. Yes. Hello. Thank you for the question, Mr. Trudel. My pleasure. I'd like to begin by saying that there's very little research done in optometry in Canada. If we compare ourselves, it might be 0.5 to 1% of research that goes to eye care. And when we look at what's done at CIHR, there's no entity within CIHR that's dedicated to eye care. But at the National Institute for Health in the United States, there's an institute specifically for eyesight. So a lot of research is done provincially. It's subsidized by the province. In Quebec, there's funding for that, or it's from foundations, private foundations. Research is done at the basic level in terms of advanced therapies for some conditions that may lead to vision loss. There are clinical trials done for new medications that can help slow down the loss of vision. So earlier, I don't know if it was you or Mr. Nelson, you talked about increasing funding, a need for more funding. If you had that additional funding, what would be the main fields of expertise where you would like to conduct research now? Yes, it would really be to look at priorities in Canada. It would probably be done in terms of disease that lead to blindness. There are new medications that can slow down vision loss, and it could be done at that level. It could also be done in terms of vision therapy. These are ways to allow people to regain some vision due to certain conditions. And then basic research that needs to be done as well. We have good institutes in Canada, including in Montreal, the Clinical Research Institute that does great research with Dr. Calouette. We have 2 universities that teach optometry. There's the University of Waterloo and the University of Montreal, and those 2 centers do their own research as well. So research would probably be concentrated in those places. Earlier, the point was raised by you or Mr. Nelson. With the pandemic, with all the screens, I have kids who are pretty young, 12 and 17, and I've seen it's a problem that's really increased during the pandemic. We know it's a factor for attention deficit. Screens can lead to trouble in that area. Could you talk about eye health and how it can be a problem? I will let our expert, Dr. Nelson, talk about that.
This one on the impact of screens, please.
Yeah, thank you very much. So, what the pandemic has shown us is that all of us are using our screens much, much more, and kids and adults and everyone, and it's highlighted the importance of vision to us. And what I think it's shown us is that we're having more people coming in with symptoms related to screen use, and that's highlighted to us that our vision is important to Canadians, and Canadians are feeling this is valuable area for the federal government to have some leadership on. If we talk specifically about kids, I talked about myopia, and we know that there are some studies that are linking increased screen use and screen time can cause increased myopia or nearsightedness, which can result in vision problems down the road and increase the risk of eye disease and pathology later on. So what this pandemic is doing, showing Canadians and reminding Canadians, don't take your vision for granted. Our vision is important, and we need the federal government to take leadership on this.
Earlier, you talked about the need for funding to support education programs for eye health. Have there already been programs like that in the past? And could you tell us about what you would like to put in place yourselves at your association?
Merci.
Thank you. Yes, in fact, to my knowledge, there hasn't been that type of campaign. In terms of eye care, it's really been neglected in the past. If we compare it to dental care and now mental health, it was a taboo for a while, and now there are a lot of campaigns in that area. We'd like to see a campaign like what was done against smoking in the past, for example. We need to educate the public and make them aware that some things are good for their eyes and some things are not. You need to have regular appointments with your eye care specialist to ensure that you're monitoring your vision and to detect problems early on and to avoid getting to much more serious problems that can lead to blindness. There haven't been campaigns like that in the past, and that's why we and our partners at the national level, we'd like to develop that for the future. You've also said that vision loss, excuse me, may I conclude?
About 6.5 minutes.
Oh, j'ai terminé.
I'm done. I'm sorry. Thank you very much for your answers.
Et je me trompe aussi.
And it wasn't Mr. Tidio, it was Mr. Trudel. My apologies. No problem.
We go now to Mr. Davies. Mr. Davies, please go ahead, 6 minutes.
Thank you, Mr. Chair. I will be sharing my time with my honorable colleague from Windsor, Mr. Massey. Ms. Travis, how many workers are currently affected by job action in the hotel industry in British Columbia?
How many? Well, I'd say thousands of workers are impacted by. Are you talking about particularly the Pacific Gateway?
No, just totally. I understand that lockout notice was served by the Hotel Association. How many workers does that affect?
About 2,000, and that includes hotels that are being bargained by the same sort of entity.
And I understand, if I can summarize this, that essentially the hotels are using the pandemic to lay off workers, let their recall rates expire, and then when the recall rates are expired, they're terminating hundreds of workers, 70% of whom are women, and many of which are people of color. Is that correct?
That's correct.
Now, this government says that it is a feminist government. It says that it claims it wants a feminist recovery. To Ms. Cardona and Ms. Dillon, what is the impact on the morale of your sisters when you see the federal government continue to use a hotel that has terminated, laid off, and locked out so many women?
It's a very disheartening feeling to be treated that way when we're in the 21st century and things are supposed to be moving forward for women.
Ms. Dillon, do you want to add anything?
Yeah, we think this is this sex and racial this is a discrimination, because 90% out of 142 workers are 90% women. More workers, again mostly women, could be terminated over the summer too.
Thank you. And I have one more question before I turn it over to Mr. Massey. So the federal government is using a hotel behind picket lines, operated by an employer who has fired and locked out hundreds of workers, mostly women. They are sending tax dollars, your tax dollars, to the hotel, to that very hotel right now, behind picket lines, operated by an employer who is facing a human rights complaint for sex and race discrimination. Can you tell us, Unite Here members, what advice you would give this federal government in those circumstances?
Lisa, do you want to take that?
Yeah, I can take that. Thank you, Michelle. I would like the federal government to stop subsidizing hotels that treat women and employees in that matter with no respect, no dignity, and making them feel like they're disposable when our jobs are not disposable and we're one of the most trained people with high skills. I don't understand why this hotel in specific is getting all this subsidizing from my tax dollars as well as yours, and letting people get fired and then get replaced by minimum wage employees.
Thank you so much. I appreciate that. Mr. Massey, I cede the floor.
Thank you, Mr. Davies, and that's atrocious and disgusting, and I thank my United workers for bringing this forward and the work they've done previous on Investment Canada as well. To Mr. Dilkins, with regards to the Public Health Agency, I know that they responded to you in a negative way. Can you maybe shed some light on terms of how seamless and the integrity of the border that you have? The City of Windsor owns the Detroit-Windsor Tunnel, and can you highlight just the logistics and the security that you offer in this program?
Yeah, thank you for the question. So being on the international border, we are very unique here in that we own our half of the Windsor-Detroit Tunnel. The City of Detroit owns their half, and it's really the only case like this between the United States and Canada. So with the approval of the board, which we got unanimous approval, we have the ability, the board said, close the tunnel down as often as you need for as long as you need to be able to facilitate vaccination at the center line. We actually drew the line in the tunnel, and the idea here is on the U.S. side, we have multiple offers from folks who live in Canada, from Canadians to facilitate, to secure the vaccine. And we're trying to find a way to do this that is maybe not the easiest. There are better solutions that are more optimal, but we're trying to find a practical way to deal with all of the logistics on both sides of the border. And we can bring people down, close the tunnel, bring them down, vaccinate them right at the border line. And then they'd be fully vaccinated Canadians. And you know what? Guess what? It would be better for everyone else involved in Canada who's waiting for a vaccine, because we've acquired other vaccine from other sources. Everyone else moves up on the list faster.
And on top of that, many of those people involved in the process would actually be Canadians because they work over in the United States. Thousands go over there every single day. So we would actually have Canadians just be inoculating Canadians just using a U.S. vaccine that's a surplus.
You're absolutely right. These would be Canadians working in Michigan in healthcare, administering the vaccines to Canadians on the other side of the line.
And lastly, can you confirm that the secure operation there? I mean, you provide an international transit system already and other types of secure elements. The Public Health Agency doesn't seem to understand, I don't think, the security that can take place in the operation that you're proposing.
I'm really clear that we don't want to do this under the cover of darkness. We'll work with U.S. CBP and CBSA to find the best way to do this that allows traffic to continue to flow. But at the end of the day, there's ways to do this so that everyone has the security and comfort that they need.
Thank you, Mr. Mass.
Thank you, Mr. Chair.
That brings our regular round of questions to an end. I believe we'll have time, for a snapper round, maybe 2 minutes per party. So on that basis, I will offer it to Ms. Rempel-Garner, if you wish.
Sure. Thank you, Chair.
2 minutes.
I'm just really having a hard time trying to wrap my brain around the fact that the federal government would fire women through the hotel quarantine program. Ms. Travis or Ms. Cardona or Ms. Dillon, perhaps Ms. Travis, this is a question for you. Are you aware if the federal government did a gender-based analysis of the hotel quarantine program? And if so, were you consulted on that?
We have no idea whether they did any sort of analysis on that. I will say that we have reached out. We reached out to the federal government months ago, the Minister of Health, back last fall, when we suspected that the hotel owner was going to use the federal quarantine as an opportunity to fire much of its staff. And so we had one conversation and we never heard from them again, and they kicked it over to PHAC. So I would say today is a good opportunity to ask PHAC why they continue to use this quarantine hotel, how much longer they plan to use it. And they have never provided a contract, and the hotel says there's no contract with the government for the use of this hotel, which is very interesting.
That's great. Are federal Liberal MPs or ministers staying at this hotel? Are you aware of that?
Right now, I think it's simply just being used as a quarantine site.
Okay, I'm just wondering if you guys were aware. How about in terms of, I know the government purports to have a anti-racism strategy. Do you believe that this program and the treatment of labor and workers fits in line with that?
I think the government has to put their money where their mouth is. We've talked a lot about a feminist, having an inclusive feminist recovery, and we think what's happening in Pacific Gateway is kind of exhibit A for what shouldn't be happening. As Elisa and Karen mentioned earlier, most of the workers who have been fired have been predominantly women and largely women of color. And the example of 90% of the housekeeping staff being terminated in a hotel that's got almost 400 rooms. Once the government leaves this hotel, they're going to need staff because folks want to travel again. And there is a real deliberate effort here to get rid of long-term staff and to replace them for less. And the government is aware of the problem, and our concern is that they haven't acted. And there's an opportunity to act.
Complicit in letting labor.
Thank you, Ms. Hempel-Garner. We go now to Ms. O'Connell. Ms. O'Connell, please, 2 minutes.
Thank you, Mr. Chair. Mayor Dilkens, thank you for coming. And as an Ontario MP myself, I understand the frustration from the Ontario government in terms of some of the vaccine rollout plans. So I'm sure you've expressed that, including some of the 4-month timelines, because I know other provinces had moved sooner to change that, but we're happy to see Ontario has come along and starting to put that pathway out for second doses. So I'm sure you've been having some fiery conversations with Premier Ford on that. In terms of some of the conversations around these doses, while I certainly appreciate and agree no doses should ever be wasted, at the crux of this though is that these doses don't belong to Canada. They belong to the US and the US people and the taxpayers who paid for them. And so we would need although we want to make sure that Canadians can access doses, we would need the state of Michigan, the US government, and frankly, even Premier Ford to support this, which is what we were able to do in Manitoba and North Dakota, that all those levels of government came to the table. So it wasn't about creativity, it was actually really precise planning. Do you have the support of the state of Michigan, the US government, and Premier Ford for the import of these vaccinations like we've had in other provinces?
Yeah, great question. Premier Ford has been very supportive of this creative effort here to get additional vaccines that are destined for the landfill into the arms of patiently waiting Canadians. And I would suggest that if it wasn't for active efforts by this federal government to make this almost impossible, that this would have already happened like you see happening in other jurisdictions between the United States and Canada. And that is the most difficult part for me to accept, is that we are telling everyone it's a race between the vaccine and the variant, and we're going to lose the race unless we get these vaccines.
Sorry, just with limited time, if the US and the state don't support it, then how is that the federal government? The Canadian federal government, if the U.S. government and the state of Michigan.
Ms. O'Connell, I'm going to have to cut you off there. I'm sorry, because we're very, very short of time. I apologize.
Sorry, can I get the answer at least?
A quick answer.
I need our government to support it first.
Thank you. C'est-à-vous maintenant, Monsieur Trudel?
Over to you now, Mr. Trudel. Go ahead, please. 2 minutes. Mr. Trudel, yes. So, and again, for the Canadian Association of Optometry, a more specific question. In a study on page 10 of your study on the loss of vision, the total cost of vision loss was $32 billion in 2019, $15 billion for total costs of vision loss, and $17.4 billion for associated costs due to a loss of quality of life. Could you elaborate a little bit on that? What do those numbers signify? Thank you. Very good question. I must admit that there's a lot of expertise in that report. There's a specific branch of Deloitte in Australia that has this expertise, so it's very specific. We like to talk about that $15 billion because that's very tangible money. Healthcare costs, productivity costs, the other segment that gets us to that 30 number, that's how they looked at losses due to quality of life. So it's not as tangible in terms of productivity, but they have a methodology to put a number to that. So at the Canadian Association, we like to focus at the $15.6 billion, which we mentioned in our comments. Just and to understand the loss of quality of life related to vision loss. Could you tell us about that? Well, if I can't go outside without having a dog with me, if I can't go to the movies, if I can't go to the grocery store, there are losses in terms of quality of life. They really have a very detailed methodology that allows them to measure all of those aspects and set a dollar value to it. But once again, that's not what we look at mainly. We look at that $15.6 billion, which is very, very tangible, that really affects the costs in terms of Canadian healthcare systems. Okay, you mentioned as well. Thank you, Mr. Trudel. Thank you.
And it's now to Mr. Davies. Mr. Davies, go ahead, please, 2 minutes.
Thank you, Ms. Travis. How long has the federal government been using this hotel behind picket lines?
Well, the government has been in this hotel since March 2020. And workers went on strike on May 3rd recently because there were so many rounds of firings, and that was in protest over the firings.
Have you brought this to the federal government's attention or any Liberal MPs that they are operating behind picket lines, giving money to this employer who's, acting in this manner?
We have made efforts to reach out to the Minister of Health multiple times since last fall and for months. And we also made sure that they were aware of what was happening in May. We made sure that they were aware of the firings, made sure that they were aware of the human rights complaint. And we've also copied other ministers on our correspondence, and we haven't heard from them.
Okay, that was going to be my question. What has been the response? You've received no response so far?
No response.
So my final question is this government has made a tagline, almost a credo of being committed to the middle class. What's the impact on wages and working conditions of this hotel strategy?
This hotel for years has provided good family supporting jobs. These have been living wage jobs. Kieran, Elisa, they've worked in this hotel for years. There are women who have worked in this hotel for 40 years and would go back tomorrow if they could. This is a very long-term group of workers, and they've stayed in the jobs because they're good jobs. And what the hotel owner wants to do is to terminate most of the workers who have already terminated most of those staff and want to replace them with folks at minimum wage and get rid of their union health benefits, eliminate a pension, and drastically roll back any sort of economic gains that have been made over the years. And that's not right. And what we're concerned that the government has not listened to what's happening here and is not acting and is continuing to roll over their stay at this particular hotel. And there are other hotels in the area that they could be using. They don't have to be using this one.
Thank you so much.
Mr. Davies. So thank you all. Thank you to all the witnesses for sharing with us your time today and for assisting us in our studies. It is most appreciated. And thank you to all the members for the great questions. And with that, we will suspend and bring in the next panel. Thank you all.
Thank you.
I call this meeting back to order. So we are resuming meeting number 42 of the House of Commons Standing Committee on Health. The committee is meeting today to study the emergency situation for Canadians in light of the COVID-19 pandemic. I'd like to welcome the witnesses. From the Department of Health, we have Dr. Stephen Lucas, Deputy Minister. From the Department of Public Works and Government Services, we have Mr. Bill Matthews, Deputy Minister. From the National Advisory Committee on Immunization, we have Dr. Matthew Tunis, Executive Secretary. With the Public Health Agency of Canada, we have Mr. Ian Stewart, President, Dr. Teresa Tam, Chief Public Health Officer, and Brigadier General Krista Brody, Vice President, Logistics and Operations. And from the Department of Public Safety and Emergency Preparedness, we have Mr. Stewart, Rob Stewart, Deputy Minister, and With that, thank you all for being here, and we appreciate your time. We're going to go straight to the questions, and we will start with Mr. Barlow. Mr. Barlow, please go ahead, 6 minutes.
Thank you very much, Mr. Chair. Appreciate everybody's time today. Maybe to Ian Stewart first, Mr. Stewart. The expert panel on the COVID-19 testing and screening recommended that the use of the government quarantine hotels be discontinued. Have you given the government advice to allow the hotel quarantine requirements to expire on June 21st?
I'll just note that I'm not able to turn on my video for some reason, Mr. Chair. Maybe it's being blocked centrally.
I'm hoping my time hasn't started then, Mr. Chair.
It was, but we'll start you over. Mr. Stewart, I did see you earlier, and it is most helpful if you can have your video on. I think it's helpful for the interpreters. Can you just...
Well, look, not to waste everybody's time, I'll ask my office to get the IT people come and see what we can fix. Meanwhile, I'm very sorry, Mr. Chair and Honourable Member, if you could just repeat the question, I can take a shot at it.
So, Mr. Barlow, I will start your time over again if you wish to go ahead with Mr. Stewart without the video.
Yeah, that's fine with me, Mr. Chair. Thanks.
Okay.
Mr. Stewart, the expert panel on the COVID-19 testing and screening recommended that the use of the government quarantine hotels be discontinued. Have you given the government advice to allow the hotel quarantine requirement to expire on June 21st?
We've given, I've got an IT tech person here over my shoulder. We've given ongoing advice around the government approved accommodations, Mr. Chair, as you can imagine. And we're taking the testing panel report very seriously, and we're giving it full consideration.
On what day will the hotel quarantine program be ended?
Mr. Chair and Honourable Member, I'm not able to answer at that time.
Good to see your video, Mr. Stewart.
Okay, thank you, Mr. Barlow.
You're welcome. Mr. Stewart, we had some pretty enlightening testimony by a group of hotel employees in the previous panel, which I think many of us on this committee found quite ridiculous in the fact that the federal government is subsidizing a company that has fired 80% of its staff, many of them women, as a way to maybe break a union. So with that in mind, Mr. Stewart, was a gender-based analysis completed for the hotel quarantine program?
Yes, we did do a gender-based analysis for our new border measures.
And was that done for the hotel quarantine program specifically?
Well, it included the totality of the program.
Would you be able to table the results of that analysis with this committee?
I will do that.
In that same vein, Mr. Stewart, was an analysis done on how the hotel quarantine program would fit into Canada's anti-racism strategy?
I'll have to look into that one, Mr. Chair and Honourable Member.
So, Mr. Stewart, we also recently learned that Prime Minister will not be staying in a hotel quarantine when he returns from the G7. What is the anticipated cost of setting up a special hotel or quarantine program for the Prime Minister and the staff when he returns from the G7?
So the information that I have at my fingertips on that topic is that the Prime Minister will be quarantining and being tested and waiting for his test results before proceeding on to his approved quarantine plan. And I don't have details of the nature that you're referring to, Honourable Member, at my fingertips at this time. We can look into your question and see what the answer is.
But by the sounds of your response, Mr. Stewart, he will not be staying in a traditional hotel quarantine. He will be doing something uniquely to the Prime Minister and his staff then?
I myself don't have knowledge of whether a decision's been taken in that regard. I know different ideas and options have been being discussed and considered, but I myself don't have the information you're asking for.
So, Mr. Stewart, I just find it strange that the Prime Minister of our country is traveling internationally, which he's asking every Canadian not to do, and there wouldn't be a very detailed strategy and plan for his quarantine upon returning home. It's bad enough when he is going to be doing activities that he is telling every Canadian not to do, and there isn't a detailed strategy or plan for his quarantining upon return home. Is that correct?
There is a detailed plan. We provided comment on different approaches. What I don't know, and you're telling me, is a specific approach has been taken, and you're asking me for the dollarization of that, and I don't have the dollarization of that.
But how is it, I guess, to that, Mr. Stewart, how is it possible that we don't have the detailed plan for his quarantine upon returning home? Or is that there and we're just unaware of what that would be?
Well, I'm saying different options were looked at, and we were providing comment on those different options, and I don't know where that's ended up. I can ask and look into that for you.
So can you provide those options that were expressed or provided, Mr. Stewart, and maybe if they would include a financial breakdown to that those options as well to committee?
I will see whether that can be provided. As you know, we're not always able to provide advice given to ministers and so on. So we will have a look exactly as you're asking.
So just with that, Mr. Stewart, I guess, why wouldn't the Prime Minister, the hotel quarantine program is in place, despite the panel saying it should be ended. Why would the Prime Minister not be just using one of the quarantine hotels that are already in place?
Well, if that decision has been taken and made public, you would be better placed perhaps to direct it to the Prime Minister or his official spokespeople.
Okay. Moving on, the minister has stated that she has consulted with the provinces on the expert panel's border measure recommendations. What were the results of those consultations? What did the provinces say about the expert panel's recommendation to end the hotel quarantine program?
Yes, Minister Haidu discussed with her health minister colleagues the findings of the report, and in fact had the panel come and talk about their findings and report, and there was conversation afterwards. Mr. Chair and MP Barlow, I don't remember off the top of my head specific comments back from individual provinces, but I'm sure it's a matter of public record we can look into and provide the details from that discussion.
Mr. Stewart, again, Congresswoman Ms. Stefaniak, who's the co-chair of the Northern Border Caucus, recently called for the United States to unilaterally open the border out of frustration with the Liberal government's lack of a plan to do so. Has your department provided any advice to the government on when the fully vaccinated people will be allowed to cross into the United States border without a quarantine?
As usual, we've done analysis and options on ways to approach this exact topic, and that advice has been put forward, and that would be maybe a question more appropriately put to a minister about what intentions they have. At this point, there's nothing public that I'm able to report on.
Thank you, Mr. Barlow.
Thanks, Mr. Chair. Yeah.
We go now to Mr. Van Bynen. Mr. Van Bynen, go ahead, please. 6 minutes.
Thank you, Mr. Chair, and thank you to our witnesses for joining us again today. I know over the past few months that some of you have made yourselves available a number of times to answer questions, and I know it's a very busy time for you, and I want you to know that the extra effort to meet with us is greatly appreciated. I want to ask Deputy Minister Matthews a few questions on accountability to taxpayers, specifically on the subject of mobile health units. There are some that have gone looking for conspiracy and cronyism where there is none, and I'll ask you to clarify this for us with a few details. What were the pandemic circumstances at the time that MHUs were identified as a possible necessity? That is, why was this anticipatory investment made?
Thank you, Mr. Chair. So this was done at a time when you were seeing things like, emergency rooms overrun with lack of space being an issue. You saw the cruise ship in the New York Harbor, and we did notice that other countries were taking steps to put in place plans for mobile hospital units or health units. And I think the important point here is just how long these things take to design and implement. The design is one piece, but also acquiring all the equipment that goes with it is another. You can't just purchase these off the shelf. So what was done at that time was to put in place contracts for two different designs. One with Weatherhaven that goes inside an existing structure, and that's the one that has been deployed in Ontario. And another model with SNC-Lavalin and partners that is designed, the Weatherhaven one's a standalone, not inside a building. The SNC and partners one is one to go inside an existing building, like an arena or something like that. So we worked to line those contracts up, and then we worked with health officials to design them and then get going in terms of procuring the equipment that would be necessary should these need to be deployed. And as you know, we've got requests from Ontario, and some have actually been deployed.
So like the rest of the world, this was an issue of thinking ahead and disaster planning. And I know that PSPC is primarily responsible for executing procurements on behalf of client departments who came to you with the MHU's request. Did they provide you with a rationale on why they were needed?
So in this case, PSPC actually used its own funding to acquire these. So in part of the estimates last year, PSPC was given additional money voted by Parliament where there was a need for procurement because we are in direct contact with suppliers and are noticing shortages to go ahead and procure things. Obviously, we consulted with health officials on the design, but the actual budget holder was PSPC in this case. And we also used that funding for things like setting up direct flights from China for PPE, contracting warehouse space in China for PPE. So it was to shorten the procurement timelines if we did notice an area of need and did that planning in advance. But obviously the detailed design was done in consultation with health officials as well as experts from National Defense who have experience in setting up mobile hospital units.
So given at the time that there were constraints, there was public health concerns, the questions were around resources. You mentioned earlier that there were two suppliers. Can you tell me why they were selected?
Based on assessments, there's not a lot of companies in this business. So we had two who have done these types of things before through the efforts often with the military in Afghanistan as well as for the US military. So we found two suppliers who were well experienced in these areas and both in the design but as well as the procurement aspects because both are important.
So known suppliers who were trusted to do the job. Can you explain what type of contract this was and why it was most appropriate in the circumstances based on the product or service needs?
So the contract had a couple of elements, Mr. Chair. Number one is the design, as I mentioned. Two is to actually procure the equipment necessary to establish these things should they be needed, because again, you have to have these on hand in advance of any request, as well as the storage of the equipment, and then the deployment if it should be used, as well as the tear down once the need has passed. So those are the various elements. So it is, some of these are to be determined in terms of future use, but those are the basic elements of the contracts.
And was that a specific type of contract?
It's effectively a mix of goods and services. So you've got, it's a total solution approach where the supplier is indeed responsible for, we jointly land on the design, but the actual procurement of the equipment, the deployment, maintenance, and then tear down is the responsibility of the supplier.
Okay, so would you consider this as a tool that's frequently or flagrantly used in your experience in procurement?
The total service package across different industries, yes. I mean, these are obviously a fairly unique asset the government has deployed. And again, they do require an awful lot of advanced planning because if there is a need, you have to effectively be out in front of it 8 months in advance. But this, turnkey type solution is used in other procurements.
So in your professional experience, was this a contract that was awarded to the right suppliers for the right job and the necessary product or service?
We are confident that we found suppliers who were capable of delivering and helping with the design. And again, two different models, which is important. So if you look at Weatherhaven, they have a good partnership with ATCO Trailers. SNC Lavalin and their partner PAE had done this type of work together before. So it was a well-known partnership for military. So well experienced in these areas, and we were quite comfortable with their expertise.
Okay, so coming back on the issue of financial accountability for goods purchased versus in demand, have the MHUs been deployed?
So we've had deployments in Ontario of the units that are standalone. So I think people may be familiar with Sunnybrook and that deployment. And there's also been discussions about potential deployment with other provinces, but to date, Ontario is the only province that has actually resulted in a deployment.
Do they continue to be available should the needs arrive?
Yes, they're absolutely still there, Mr. Chair, should there be a call. It's one of these assets that you hope you never have to deploy, frankly, but should there be a need, they're available. There's one of each model available for deployment should it be needed.
Good. And would they be available again in the event if there's a possible future health crisis? That is, do they have an expiry date?
Well, obviously the equipment as part of these units, some of it has expiry dates, but the actual, I'll call it vehicle itself, is available for some time should it be needed in the future. And we're in discussions with our colleagues about the eventual home for these things in terms of which department would retain responsibility.
And Mr. Van Buynens, you're way over. Sorry, I was distracted. I apologize.
Okay.
Thank you. Go now to New Zealand.
Mr. Chair, if I just might, I I wasn't keeping track either, but it seemed like that was a very, very long time. Can you tell me how many minutes were given to the Liberals there?
Mr. Van Bynen had an extra 37 seconds.
Oh, that's all? Okay, thank you.
And it's all my fault. I apologize to the committee. We go now to, nous allons maintenant, Monsieur Thériault.
We go now to Mr. Thériault. Go ahead, please. 6 minutes. Thank you, Mr. Chair. My question will be to the Department of Health, Dr. Lucas, perhaps also Mr. Matthews. On May 3rd of 2021, the department approved Emergency Use Authorization Number 2 in relation to COVID-19 to replace the first emergency decree of 2020 and has the optional use authorization for clinical trials for possible future medications and medical devices related to COVID-19 with regulatory flexibility so that other types of clinical trials can be done efficiently. On Health Canada's website, it's highlighted that the emergency use authorization makes Canada an attractive place for clinical trials, but that doesn't improve Canadians' access to therapies against COVID-19. Could you explain what those regulatory flexibilities entail?
Thank you, Mr. Chair. So indeed, Health Canada did renew the interim order for clinical trials, part of a series of interim orders brought in place during the course of the pandemic to enable the rapid review of medical devices, clinical trials, vaccines, and therapeutic products, and measures, concurrent to ensure their safety, quality, and efficacy. The clinical trial interim order.
How is it that Canada is more attractive with that regulatory flexibility? What makes Canada attractive? Why would you want to do clinical trials here in Canada? That's my question.
So I'll, Mr. Chair, note a number of areas. These changes allowed for multiple site clinical trials, shortened review periods, allowed for the use of multiple investigators at these sites. And so we're really intended to enable, as the member noted, the attraction of clinical trials of which we have over 100 now associated with COVID vaccines and therapies. We've also launched, I think on May 25th, a consultation on clinical trials modernization, looking at updating the regulatory framework across all product lines, building on some of the experience with the interim order, which was renewed in May.
Est-ce que vous envisagez...
Do you foresee that regulatory flexibility being extended? Because recently, a number of researchers, companies, patient organizations have come before the committee to tell us, to warn us against the new guidelines of the PMPRB. According to them, it's not in Canada's interest. It would make Canada and the provinces much less attractive for clinical trials. Have you ensured that the price that we pay for drugs isn't excessive? What are the measures you've taken to control the prices of drugs related to this research on COVID-19 here in Canada?
So, Mr. Chair, the honourable member asked a few questions. I'll deal with those in turn. On the first, as I indicated, Health Canada has renewed the interim order for clinical trials associated with COVID-19 vaccines and therapies, and this allows for the ability to attract those trials, as indeed has been the case, and rapidly approve and monitor them using a series of flexibilities. That approach is being embedded in along with others to ensure a competitive innovative environment for attracting clinical trials in the clinical trial modernization consultations that have been launched. We had in 2020 a significant number above average of new drug submissions. And as I said, over 100 COVID-related clinical trial applications. The government did promulgate the regulations pertaining to the Patented Medicines Price Review Board in August 2019, and the coming into force of those is currently slated for the beginning of July.
Est-ce que vous allez la reporter, cette...
Will you push that deadline back? Because you want to put in place a reform that would better control excessive prices, and you tell the provinces that they should be revealing the prices that they pay, and you're not letting us see the contracts and see what you're paying for medications related to COVID-19. Don't you see that as contradictory?
Mr. Chair, I will indicate that the coming into force of the patented medicine price regulations currently slated for July 1st. They have been deferred in the past due to the pandemic and consultation on the guidelines.
Les contradictions,
the contradiction between what you're
contrat.
That's all, Mr. Tidio. The contradiction in terms of contracts. I'll ask again. Could you answer the... Many people are speaking at the same time. It would be a short answer, please, Mr. Lucas.
To the element of the regulations pertaining to confidential rebates that was addressed and contested in a court decision, which is currently under appeal. And so that element is not going forward as a result of that court decision, which proceeds in the courts.
Merci, Monsieur Thériault.
Thank you, Mr. Tidio.
We now go to Mr. Davies. Mr. Davies, you have officially 6 minutes. I will give you another 45 seconds because of Mr. Thériault and Mr. Van Bynen. I went over, and I'll make it up to the Conservatives on the next round. So thank you all. And Mr. Davies, go ahead. 6 minutes, 45 seconds.
Thank you, Mr. Chair. That's very fair of you. Mr. Stewart, why is this federal government, who claims to be feminist and committed to expanding the middle class, using and effectively subsidizing a hotel, that's the Pacific Gateway Hotel in Vancouver, that is behind picket lines, that has fired workers, primarily women and people of color, is replacing long-term family-sustaining jobs with minimum wage employees with no benefits, and who is facing a gender and race-based human rights complaint, particularly when there's other hotels in the area that could be used for quarantine?
Mr. Chair and Honourable Member, thank you for that question. When we entered into our contract with that hotel, they were not in a strike position at that time. From what you're saying, you're indicating that things have progressed. We use the hotel facility, and we also employ hotel staff in the back office elements of the operation. However, the frontline work is done by infectious control specialists, which hotels do not have. So I guess what I would say is we'll look into the situation you're describing. However, it's not consistent with my understanding.
Mrs. Stewart, can you produce that contract to this committee, please?
Could we produce our contract with our designated quarantine facility in British Columbia?
Yeah, with the hotel.
Well, we will have a look at that, sir, in response to your request.
Okay. Dr. Tam, on May 17, just a couple of weeks ago, the World Health Organization issued a statement to provide clarification and guidance on the issue of expiry dates of COVID-19 vaccines. It said the following: any vaccine that has passed its expiry date, including Covishield, should not be administered. While discarding vaccines is deeply regrettable in the context of any immunization program, WHO recommends that these expired doses should be removed from the distribution chain and safely disposed. Why is Canada ignoring that recommendation?
So, Mr. Chair, I think this is more of a regulatory question. But when I certainly,
well, who should answer, Dr. Tam? If you can't answer him, who's best placed to answer that question as to why we're ignoring that?
I think I would suggest Dr. Lucas, but all I would say is that it's when a regulator accepts a manufacturer's submission and data on extension of shelf life, that is reviewed by the regulator, and then when the regulator approves of that, and the vaccine then is not considered as expired. So I think that's a regulatory issue.
Dr. Lucas, can you tell me why Canada is at odds with what the WHO is recommending?
Mr. Chair, I would simply say that there are no expired doses being used in Canada. The Health Canada received a submission in late May from AstraZeneca seeking a 1-month extension on the doses that were to have expired on May 31st. The Health Canada scientific reviewers reviewed the data provided in detail and issued a regulatory decision extending those doses to July 1st.
Okay. Dr. Tunis, many Canadians, of course, have received their first dose of AstraZeneca, and now many of them are coming up for their second dose. Most provinces, if not all of them, I'm not sure, I think most are not using the drug due to VITT concerns and supply issues. And of course, on the mixing data of using AstraZeneca with messenger RNA vaccines, that is apparently not conclusive to this day. So what is NACI's recommendation to Canadians who received their first dose of AstraZeneca in terms of what they should be taking for their second dose? Should it be AstraZeneca or should it be a messenger RNA vaccine? And what data is that answer based on, please?
Sure. Thank you for the question, Mr. Chair. So yeah, NACI has published new advice as of last week on the topic of mixing vaccine schedules. And NACI has now recommended that either AstraZeneca COVID-19 vaccine or an mRNA COVID-19 vaccine product may be offered for the subsequent dose in a vaccine series started with AstraZeneca. So that either may be offered. The evidence that was used by the committee to issue that recommendation included both safety evidence and also evidence on the immune response. So there were several studies at the time, one from the United Kingdom, one from Germany, and one from Spain, all of which reported a good safety profile when vaccines were mixed between AstraZeneca and mRNA vaccines. And also one study on the immune response from Spain. Since that time, I'll note that there have been a number of studies that came out pre-printed last week as well, two from Germany on the topic of immune responses when vaccines are mixed. So the committee has made that recommendation based on the risk of VITT or thrombosis with thrombocytopenia after first and second doses of AstraZeneca. Also, they considered the possibility of increased short-term reactogenicity with a mixed schedule, and emerging data on the immune response from that mixed schedule that I mentioned. So that was all.
Can I just interrupt, Dr. Tunis, just put something to, last week, Dr. Andrew Morris, he expressed concern that individuals cannot really receive informed consent regarding the risk of VITT prior to getting a second dose of AstraZeneca, given the constant changing of the data being received about the incidence of VITT. He had numbers that show that it's continually changing. So although there's emerging data, is there conclusive data at this point to make an informed decision on the safety concerns of AstraZeneca or on mixed dosage, or was that data shifting and moving?
This is an excellent point. And I would say as many data elements in this pandemic and the vaccine responses, that does continue to shift. So the risk of VITT following AstraZeneca vaccine, we have seen it change over time.
and it does continue to change. So that informed consent process would ideally include a discussion about what is known, and also the fact that it has been changing over time. And NACI has acknowledged that in their advice to the government, that informed consent should include discussion of that, which does change. On the topic of the mixed schedules, those are being implemented in a number of countries around the world. The evidence is emerging and will continue to emerge over months as more studies come out exploring that topic. But there have been a number of studies that were reviewed by NACI when making this advice, and that continue to emerge. So again, on the topic of mixed schedules, NACI felt very comfortable recommending, as many other countries have now done, that mRNA can be used to complete that series. But yes, they acknowledge that the evidence does continue to change and to evolve, and we may learn more about whether a mixed schedule is in fact generate a stronger immune response. Those things continue to emerge.
Thank you, Mr. Davies. So that brings round one to a close. We'll start round two with Mr. Maguire. Mr. Maguire, officially you have 5 minutes. We'll give you 5:45 because of.
Thank you, Mr. Chair. Thanks very much. I just wanted to ask Dr. Lewis some questions here. The contract with Switch Health to oversee post-arrival coronavirus tests for travelers has been renewed despite media reports that the company has bungled the process. I've raised this a number of times in our meetings in the past. So what communications did your department have with the government of Ontario about an RFP for post-arrival testing?
Mr. Chair, I'll turn that question to Ian Stewart from the Public Health Agency.
Well, Mr. Stewart or Mr. Lucas, are you not in charge of that? I mean,
in terms of the work on the border testing, that is the responsibility of the Public Health Agency.
Yes, I've been in touch with them many times, Mr. Stewart.
Hello, sir. How are you today? Honorable member and Mr. Chair, thanks for the question. Actually, the contracting aspect would probably be better placed with Bill Matthews, but with respect to Switch Health, as you point out, they are a service provider of the Public Health Agency.
I just asked what communications did your department have with the Ontario government about the post-arrival testing?
The renewal of the contract for post-arrival testing?
Yes, the RFP.
Yes, okay, that would be Bill Matthews.
Thank you, Mr. Chair. So no direct discussions with the Ontario government that I'm aware of, but I'm happy to check and see if...
What communications did your department have then, Mr. Matthews, with the government of Ontario prior to the RFP being given to Switch Health?
So the federal government ran its own procurement process for the testing, and Switch was the recipient of the contract. And I'm happy to go back with my staff to see if there was any contact with the Ontario government, but I'm not aware of any, but I'm happy to take that back and see if there was others.
Did Switch Health ask anyone in your department to change the day 10 test to a day 8 test?
No, sir.
That was, excuse me for jumping in, Mr. Chair and Honourable Member, that was an operational decision made by the public health officials.
And so on a per capita, or pardon me, per the contract that we were talking about earlier, Mr. Stewart, with Switch Health, are they currently legally obligated to ensure samples collected via the online portal are collected under the supervision of a nurse?
It actually varies by jurisdiction. They are not required to collect the samples under the jurisdiction of a nurse. It varies by province, the appropriate healthcare professional and so on, different language in different provinces. That being said, of their workforce, from memory, about 1,029 are in fact nurses. And then I think there were 29 who were not nurses. After we found out the non-nurses were involved in supervision, even though it wasn't required under the province, we asked them to reassign those staff to other duties to ensure that appropriately trained medical teams were looking over the supervision.
Yeah, I know this, and I'm assuming that that's the same in all provinces in Canada. The situation that I've raised this 2 or 3 times about the incompetency of picking up these vaccines in rural Canada, and it continues unabated at this point. They're very quick to call. The case that I had in one of my communities as of yesterday that you're familiar with, Mr. Stewart, was PHAC was quite ready to call them to make sure they were still in quarantine as late as yesterday, from a May 15th crossing back into Canada where the young individual had 2 vaccines, fully vaccinated, coming from college in the U.S. Has had 2 positive, or 2 very negative tests, pardon me, in the last 5 days, again here in Canada, and still is in quarantine and doesn't know what he has to do. He's never been told. He doesn't want an apology that you've offered on this situation, and it's not resolved for the future. So can someone contact him, or how do you get a hold of regular people that are stuck in this dilemma? He needs to be contacted so that he knows how to get out of quarantine so he can go to work.
Thank you, sir. And Mr. Chair, first of all, I want to thank you for bringing the matter to my attention, honorable member. As you know, obviously we're very distressed at the situation we've created for him. Secondly, we have in fact, in response, set up a change in procedure. So somebody in a similar circumstance now will be offered the opportunity to test locally instead of continuing to wait in a situation of the nature you described. So thank you again for bringing that to my attention.
These tests though have, he did his day 1 test and it sat for 6 days. It was finally picked up after constant phoning every day. His day 8 test was sat for another week before it was picked up, and it never was picked up. He had to drive at 100 kilometers to Brandon to the COVID testing site. And so these are the kinds of things that people are faced with in rural Canada, and it's completely against the contract. That's why I'm asking about information in regards to these contracts and stuff, because this is an incompetency, and the major courier couldn't even find a local address in a small town in my area. And Uber, which was put up as an alternative, doesn't exist in rural Canada. So what are these people supposed to do in regards to the viability of those tests after sitting for 6 to 8 days?
They're supposed to phone Switch Health, and we've changed the operating procedure to make sure what you just described doesn't happen.
Oh, believe me, they phone Switch Health every day.
No, today, effective today, we have changed it so that that situation does not reoccur.
Okay, but appreciate that, because it's been a huge dilemma in rural Canada, and particularly for many families in my area here in southwest Manitoba. And so I just wanted to bring that to your attention again, and I trust that someone will contact them today, these people in the past, to make sure that they know what to do to get out of quarantine.
Thank you.
Will that occur?
Yes.
Thank you, Mr. McGuire. We go now to Mr. Kellaway. Mr. Kellaway, please go ahead, 5 minutes.
Thank you, Mr. Chair, and hello to my colleagues. And again, thank you to the witnesses for being here. My first question will be directed towards Dr. Tam. So last week, Nova Scotia Premier Ian Rankin and the Chief Medical Health Officer, Dr. Strang, announced that beginning tomorrow, rotational workers with no symptoms and have been fully vaccinated at least 2 weeks before arriving in Nova Scotia will no longer need to self-isolate. The catch is that they must get tested on day 1 or day 2, again on day 5 or 6, and again on day 12, 13, or 14. My understanding is that those who have 1 dose and are not coming from an exposure hotspot are required to self-isolate for 7 days after they have proof of 2 negative test results. So Dr. Tam, as we start looking at ways to safely reopen our national borders, what would you expect it could look like, and what are your concerns around reopening, if any?
Thank you for that question. Of course, domestic borders are in the realms of the provincial jurisdiction, but we are sharing this kind of discussion amongst chief medical officers of health. And of course, even the international border, whilst it's in federal jurisdiction, one has to have these discussions with the province and territories, particularly as it pertains to whether Canada in its domestic situation has its third wave or resurgence under control. And also we're discussing, well, what does it mean to be vaccinated fully? Those kind of discussions. And we've tabled also the expert panel's report, not only to the ministers, but the deputy ministers and also the special advisory committee. So those kind of recommendations will be taken into account as the decisions are being made by the federal government on our border pathway forwards. But I think some of the public health parameters, vaccine effectiveness information, as well as the other more operational considerations, sometimes quite similar between what the provinces consider and also what the federal government has to consider for the international border. So these elements, there are some parallels that one could draw.
Thank you, Dr. Tam. Last week, NACI advised that Canadians are able to move forward in terms of mixing and matching dosages, and that all vaccines approved by Health Canada are safe and effective. So I believe in one of our earlier committee meetings with the folks from PHAC, we learned that there were several international studies that were informing NACI's decision. And we have Dr. Tunis here, as well as some folks from PHAC. So I'll open this question to you folks. Can you tell the committee what the new recommendations say? And what are the main takeaways from those international studies?
Thank you for the question, Mr. Chair. So yes, I'll start with this. So last week, NACI recommended that either AstraZeneca, Covishield COVID-19 vaccine, or an mRNA vaccine may be offered for the subsequent dose in a series started with AstraZeneca or Covishield COVID-19 vaccine, and that the previous dose should be counted and the series need not be restarted. So NACI made this recommendation at the time informed by several studies from the international landscape, one from Spain, one from the United Kingdom, and one from Germany, all of which showed that when you provide an mRNA vaccine after an AstraZeneca vaccine, it is safe. And there were actually multiple intervals studied, 4 weeks and also 8 to 12 weeks. So at any of those intervals studied, overall, the vaccine was found, the mixed schedule was found to be safe. They also looked at immune response data from that study from Spain as well, which showed that you do in fact boost the immune response when the mRNA vaccine is provided after the AstraZeneca vaccine. Since that time, there have been several studies that have also come out from Germany looking at the immune response that replicate that finding as well, that you get a good strong boost to the immune response when you follow AstraZeneca vaccine with Pfizer. So that was underpinning NACI's recommendations, that they had seen studies from multiple countries looking at multiple schedules, looking at safety, and now also the immune response that demonstrated that this is a strategy that can be used. And so provinces and territories are now looking at this and how they integrate that into their second dose approaches across the country. Thank you.
Excuse me, committee. We have the bells ringing for the vote. I need unanimous consent to carry on. Do we have unanimous consent to carry on for another 15 minutes?
Yes.
Okay, very well, thank you. Mr. Callaway, carry on. You have 20 seconds left.
Well, I will give my 20 seconds either up or to someone else, but use your discretion. But just thanks for the witnesses again. It seems like we've been together for more than a year plus, but just again, thank you for all the work you're doing. It's not easy, and I know we all appreciate the work you do and the people that work under you. Thanks again.
Great, thank you all, and thank you, Mr. Callaway. Your actually time is up now with the thank you, so thank you. We go now to Ms. Rempel-Garner, please. Go ahead, 5 minutes.
Thank you, Chair. Dr. Lucas, just picking up a question that my colleague Mr. Davies asked you, can you confirm that no doses that have passed the date of manufacturer labeled expiry have been administered in Canada?
Yes, Mr. Chair, to the best of my knowledge, that's the case. As I'd indicated, the AstraZeneca doses that were to have expired on May 31st, subject to a request from AstraZeneca in providing data to extend that expiry by a month, were reviewed and approved.
So the doses that were originally set to expire on May 31st have been administered. You guys just changed the expiry date, is what you're saying.
Well, we received a robust regulatory package at the request of the manufacturer. It was reviewed thoroughly by the scientific review staff. On the basis of that review, the expiry was changed to the beginning of July. Therefore, the doses have not expired.
Okay, so it just was a little bit misleading what you had said to Mr. Davies, so I wanted to get that on the record. Brigadier General Brody, first of all, congratulations on your appointment. Well deserved. I'm wondering if the government has given you any advice on accepting surplus vaccines from the US, such as what is being requested by the Mayor of Windsor.
Thank you, Mr. Chair and Honourable Member. No, I've not received any advice, and that's not a responsibility that falls within my portfolio at the Public Health Agency. Thank you.
Okay. Have you talked to anybody within PHAC or Health Canada or the Minister's Office about accepting these surplus doses from the US?
Mr. Chair, Honourable Member, certainly there are live ongoing discussions on a regular basis with respect to the donation portfolio acceptance of other doses and whether or not they're coming in based on offers or on APA agreements. So yes, there are many discussions in that regard.
Are the Detroit doses part of those discussions?
Mr. Chair, Honourable Member, so that's not part of the discussions that I've had, no.
Thank you. Mr. Stewart, picking up on some of the questions my colleague John Barlow was asking, has the Prime Minister's office asked you for any advice regarding the Prime Minister's quarantine requirements?
The Prime Minister's office has not asked us for advice regarding quarantine requirements. Okay. The Privy Council office has had discussions with us regarding.
In that advice that you provided to the PCO, was there any advice that you provided to them as to why the Prime Minister couldn't stay at a current designated hotel quarantine site?
We've looked at different scenarios and provided comments. We didn't provide advice of the nature you're requesting, Honourable Member.
Is there any reason why the Prime Minister couldn't stay at a designated existing quarantine hotel site?
Mr. Chair, I'm not well positioned to answer an open question of that nature.
Well, I mean, you are the head of PHAC, so is there
any
reason?
Many causal factors. The way you're phrasing the question is just very open-ended.
Sure. Is there a reason why the Prime Minister of Canada shouldn't stay at a hotel quarantine site, but every other Canadian would? Like, what makes him special?
Those would be considerations that might be best to discuss with the Privy Council office. They're more aware of security threats and other things that I might not be aware of.
Are there any public health reasons why he couldn't stay at a quarantine hotel?
There are a number of options under which the Prime Minister could be consistent with having a day one test and waiting for the results and then going to quarantine, which are the essential elements of our policy.
But that would be a different process than every other Canadian would go through. Is that correct?
It depends on which way that it was structured.
Okay. Do you think that the Prime Minister's security concerns are greater than the women who were allegedly sexually assaulted at the hotel quarantine program?
Which women are you referring to?
There were reports of sexual assault occurring at one hotel. So I'm just wondering if you deem their security concerns greater or less than the Prime Minister's.
It was a designated quarantine facility. There were no such sexual assaults of the nature you're describing alleged, to my knowledge. There was a newspaper story.
I feel like you're gaslighting us.
That was a newspaper story about a designated quarantine facility, is what I'm trying to say, which is a different category.
A quarantine hotel.
It's not a quarantine hotel, it's a designated quarantine facility.
Again, so a woman who was allegedly sexually assaulted at a quarantine hotel run by the federal government, would her security concerns be greater or less than the Prime Minister's?
I wouldn't know how to begin to answer a question structured that way, but thank you.
And I think that's the problem.
Thank you, Ms. Rumpel-Garner. We go now to Ms. O'Connell. Ms. O'Connell, please go ahead. 5 minutes.
Thank you, Mr. Chair. Sorry, I didn't know if I'd have a chance there. So quickly, Mr. Stewart, just picking up on that, it's my understanding, or Dr. Tam, whomever can answer, it's my understanding the Prime Minister, as well as any security detail, media, and staff are all going to follow the quarantine protocol that Canadians would have to follow, which is returning and staying in a hotel to quarantine until they receive their test. Given the fact that, again, to travel for these meetings requires security as well as media traveling as well as part of this, and the entire group that would be attending would be subject to quarantining in a hotel just like anybody else in terms of the quarantine protocols. Is that accurate?
The essential elements, as you're saying, the essential elements are that they are tested on arrival, that they're held in a safe space until the results are known, and then they're released into an approved quarantine. And there's different ways to do that.
And so part of that is to just ensure that anyone who's had international travel, that if they've been exposed, that doesn't come into our communities, which is ultimately the goal until those tests can return, correct?
The idea, as I'm saying, the essential elements are, as you're saying, Honourable Member, that people are tested on arrival. They're held until the test result is provided, and then they go into quarantine. So I think the answer to your question is yes.
Thank you. And so just quickly, because I don't have much time, in the first panel, we heard about the Mayor of Windsor talking about doses from the US. I'm not sure who's been engaged in these conversations, so feel free to jump in. But I do recall the conversations around, for example, truck drivers in Manitoba and North Dakota, and there was a significant amount of work done with the Premier, the Governor, and local authorities to make this process happen. It's my understanding that the US federal government has determined that travel for vaccination is not essential. The governor of Michigan has not actually offered these doses to Canada, that perhaps it's some pharmacies who may have extra doses and surely don't want them wasted, and I understand that. But ultimately, these doses are owned and paid for by American taxpayers. So unless they are willing to give them to us, whether we say we want them or not, that the owners of these doses must actually indicate providing them to us. Is that a fair and accurate summary of where the issue is? It's not the fact that the Canadian government doesn't want to access doses. In fact, we're working with the US federal government every single day to get surplus doses, but these particular doses, that the local government authorities have not authorized Canada to have them.
Yes, is that in summary is our understanding. And I would also note, by the way, about 2 hours ago, we delivered our 30 millionth dose in Canada to the provinces and territories.
Thank you. And so that even if Canada's position was, yes, we would welcome these extra doses from Detroit, that again, we don't own them, and therefore they can only be provided if the state government and the US federal government authorizes that. Essentially it would be an export.
Yes, and it would have to go through the regulatory approvals of that regard. And Steve Lucas, of course, can speak more to that. But yes, you're right. It's owned by the federal government of the United States.
Right, because Janssen is an example that or even any doses that we've had donated or given to us by the US, that they also have to have all that information reviewed, because Canadians expect that any doses used here, even if the US has a system that we're, comfortable with, that we have a regulatory process that has to live up to the standards of Health Canada.
That's exactly the case, Mr. Chair. Any vaccines imported into Canada need to meet a series of requirements in addition to being approved for use by Health Canada, including understanding the specific lot number of the doses, the quantities, who the importer is. All of this information is well outlined. We've shared it with the provinces, and it's available on our website, and that would need to be provided for any case where there's authorized importation.
And do you know if Premier Ford has asked
sorry,
the
Ms.
governor? Sorry,
Ms. O'Connell, I have to cut you off here. We're really running short of time, and thank you. I appreciate it. Monsieur Thériault, allez-y.
Mr. Thériault, go ahead, please. 2.5 minutes. Thank you, Mr. Chair. Dr. Lucas, Health Canada highlights that the interim order continues to make Canada an attractive place for clinical trials. So you know the importance of clinical trials so that patients can have access to therapeutic options, which is what's true for COVID-19 is also true for a deadly disease, a rare disease, a disease like cancer or in immunology. Do you not agree with me?
Monsieur le Président. Oui,
no. Mr. Chair, yes, no?
Has an attractive clinical trial regime for all health products, and has put in place special measures through an interim order for COVID-related products, and we have embarked on the modernization of the clinical trials regime.
That's not my question. I don't know if you've understood me. I've understood. So my question is, do you agree with me that what's true for COVID is also true for a rare disease or another deadly disease? Yes or no? Yes or no? Yes. Yes, thank you. Now, I've lost time. So if that's true, it's important to maintain. In that flexibility, what would we not see in PMPRB? Are you telling us indirectly that you haven't controlled the excess levels of prices in that flexibility? If that's not the case, what is there in PMPRB to reassure a patient who has a rare disease? A patient with a rare disease, is that patient less important than a COVID patient? We're saying here that your reform will mean that there will be fewer clinical trials.
Mr. Chair, I think the record shows that Canada is an attractive country for clinical trials. As I'd indicated, we have a very competitive regime. It was special measures were put in place for COVID-related clinical trials, but otherwise, we have a competitive regime which we are setting to modernize. We've invested through the budget. The government invested $250 million to strengthen the clinical trials research. National networks have been established, and these factors have led to continued submission of clinical trials in Canada.
How can we ensure that you've really controlled excessive prices when we don't have access to the contracts?
The Patented Medicine Price Review Board has a series of tests and regulations in place. New ones were promulgated and are slated to come into force on July 1st, 2021. Those elements pertaining to confidential rebates have been the subject of a court decision and will not be part of that package as it's before the court.
Thank you. Merci, Monsieur Thériault.
Thank you, Mr. Thériault.
Mr. Davies, we are very short of time, so if you could, you have 2 minutes and 30 seconds.
Thank you, Dr. Lucas. On May 29th, Health Canada announced it was granting a 1-month extension to the shelf life of AstraZeneca vaccines in Canada that were set to expire 2 days later on May 31st. Sorry, you're telling me that that AstraZeneca supplied Health Canada with clinical data that showed they had control groups and non-control groups administered AstraZeneca that had been expired for 30 days and AstraZeneca that had not been expired, and show these studies showed no difference in efficacy or safety. Is that the data that you were supplied with?
Mr. Chair, I would indicate that the data package pertained to the stability of the vaccines and other data that indicated their continued viability. They were reviewed in detail by the team of scientific reviewers at Health Canada, who rendered a decision through the independent regulatory function here at Health Canada.
I just find it odd that a maker of a drug happens to just spontaneously supply Health Canada with data that says that the label instructions on medication that says it's going to expire doesn't apply. Did any other drug manufacturers do that? Any other vaccine manufacturers?
Mr. Chair, to the best of my knowledge, that has not been the case with other vaccine manufacturers. But in other health products areas, manufacturers do apply for I just want to know about
vaccines, sir. I'm just asking about vaccines. I want to move on. The COVID-19 Testing and Screening Expert Advisory Panel has recommended that Canada should have a system in place to validate proof of vaccination for arriving travelers as soon as possible. Does the federal government intend to establish such a system? And if so, can you confirm when it will be in place?
Mr. Stewart? Yes, I'm sorry. I just didn't hit my mute properly. We are looking at options to respond to exactly the scenario you're talking about. Analysis and work is underway in that regard. No decisions have been taken at this time.
And will Canada make a firm commitment to donate vaccine doses to low-income countries at this week's G7 summit?
Considerations being given to how best to support international vaccination. Obviously, it's a huge priority to ensure that the world is being vaccinated.
Thank you, Mr. Davies.
Oh, thank you. Thank you for the answers.
And thank you to all the members for all the great questions. And we are very short of time. Thank you to the witnesses once again for appearing before us. I know you're all frequent flyers, and it's good to see you all. And thank you for the work you do on an ongoing basis to keep us all safe and secure. And I'd like also to thank the interpreters. I know there's a lot of sickness in the ranks, and I really do appreciate. I apologize that we've gone over, but thank you all for your work on an ongoing basis, as well as certainly all of the House staff. So with that, we are now adjourned. Thank you all.